Patients who require the use of traction after traumatic injury, orthopedic surgery, or as a corrective measure need specialized nursing care. This involves an understanding of traction equipment, methods, and mechanics in order to provide patient care and maximize patient comfort. Patients in traction run the risk of developing certain complications. By using careful monitoring and assessment techniques, nurses can be very effective in the prevention and early detection of these complications. Traction is defined as the application of a pulling force to an extremity or some other part of the body. At the same time, an opposing pull or countertraction is applied. Countertraction can be provided by the patient's own body or the position of the bed. Traction force is created with a system of weights and pulleys. The weights provide a constant force, while the pulleys provide the constant direction of the force. Traction is used to reduce a fracture and maintain alignment of the bone fragments. Reduction of a fracture is defined as restoring or repositioning bones to their normal anatomical position. Traction is also used to reduce a dislocated joint, prevent or reduce muscle spasm and relieve pain, prevent, minimize, or correct deformities, promote the rest of a diseased or injured part of the body, and allow for patient exercise, well-being, and comfort. There are three basic types of traction: manual, skin, and skeletal. Manual traction is applied by using the hands to exert a pulling force on the joint or limb which is to be realigned. It is commonly used during the application of a cast or to reduce a fracture while mechanical traction is being applied or readjusted. Manual traction should be applied smoothly and firmly and is supervised by a physician. Skin traction involves the application of a pulling force directly to the skin through the use of adhesive traction tape or non-adhesive devices such as belts, halters, or boots. It is used on a short-term basis, usually less than 2 weeks. It is often used as a temporary measure prior to more definitive treatment, such as surgery. A light pull of 5 to 8 pounds is used. Skeletal traction uses a pin, wire, or tongs inserted through part of the skeleton to apply a continuous force directly to the client's bone. This type of traction maintains the reduction of the fractured limb and controls rotation. Skeletal traction is used when longer periods of immobilization are required. Weights from 15 to 40 pounds are commonly used. Skeletal traction allows for joint movement, exercise of non-affected muscles, and isometric exercises of the affected muscles. Straight line traction has the pulling force applied in only one direction. It is one of the oldest and simplest forms of traction and is most commonly seen in Buck's traction. This traction is affixed to the limb at only one point and then is attached to a weight using one or more pulleys. The patient's own body weight provides the countertraction. Sometimes inadequate countertraction may cause the patient to continually slide down toward the traction pull. In these cases, it may be necessary to provide increased countertraction by tilting the bed away from the traction force. This is done by placing the bed in Trendelenburg position. In some cases, an injury will require a long period of healing, during which time the injured area must be supported and immobilized to maintain proper bone alignment and growth. Your patient's continued physical and emotional health may greatly depend on his ability to move about as much as possible during this period, which could last from several weeks to several months. Balance suspension, used along with traction, allows for this type of movement. A system of weights and pulleys allows the injured limb to float over the bed in an elevated position. This facilitates using a bedpan, changing bed linens, and allows patient movement and exercise with minimal disturbance to the fracture or joint. The pull of traction can be hindered by any type of friction that reduces its efficiency. To prevent friction, make sure that bed linens are not tucked tightly around the patient or the traction cords. Do not allow the spreader or footplate to rest against the end of the bed. Inspect the weights to make sure they are hanging freely and away from the bed. Check that knots are clear of the pulleys and that there are no clamps or hooks resting against the bed frame. Check frequently to see that the pulleys are working properly and that ropes run in the middle of the pulleys. Inspect all frame bolts for tightness. It is very important to maintain the line of pull that has been established by the physician. With few exceptions, traction must be continuous. The patient should be in proper anatomical alignment. Do not remove traction or change the amount of weight without a physician's order. Patients going to the operating room are usually wheeled there in bed, in traction.
When learning to tie a traction knot, remember this simple phrase: up and over, down and over, up and through. After you have tied the traction cord, allow about 2 to 4 inches at the end. This will allow you to later adjust the knot without having to replace the entire cord. Also remember to secure all knot ends with tape.
The complications of traction can vary widely depending upon the type of traction, the age, size, and general medical condition of the patient, and the location of the injury. Nurses should assess patients in traction for the following conditions: neurovascular changes distal to the traction, skin or soft tissue damage, especially at pressure points and under slings or other traction devices, signs and symptoms of infection, especially at any pin sites, deep vein thrombosis due to venous stasis or possible vein wall injury, signs and symptoms of respiratory problems including pulmonary emboli or fat emboli. Pulmonary emboli are the obstruction of the pulmonary artery by a thrombus, usually from the lower extremity. Fat emboli are caused by the release of fat globules from bone marrow during a crushing injury or long bone fracture. Patients present with respiratory distress and confusion. Signs and symptoms of compartment syndrome, an orthopedic emergency in which arteries and nerves are compressed by swelling tissues. The hallmarks of compartment syndrome are unrelieved pain, diminishing pulses, pallor, paresthesias, and pain on passive motion. A neurovascular assessment of the involved extremity is a critical component of orthopedic nursing care. It includes verbal interaction with your patient, inspection, and physical touch. The functioning of both the nerves and blood vessels is evaluated. Perform the assessment on the unaffected limb first, note the results, and then assess the affected area, comparing the two. Many agencies provide a special neurovascular flow sheet on which results are recorded. Admission and preoperative assessments are mandatory in order to provide a baseline for later comparisons, especially after surgery. Nerves are tested for both sensation and motor function. To check for sensation, instruct the patient to look away. Lightly touch the area being examined with your finger. Ask the patient if he felt the touch and how it compared with a touch to the same area on the opposite limb. Any numbness or tingling could indicate neurovascular problems and should be noted and reported. To check for motor nerve function, you will ask the patient to perform some specific movements. The nerves assessed in the upper extremities are the radial, median, and ulnar nerves. To test radial nerve motor function, have the patient extend his wrist or knuckles. Test for radial nerve sensation at the thenar space, which is the web of skin on the back of the hand between the thumb and the index finger. Note the results, comparing them with the uninjured hand. Test median nerve function by asking the patient to touch his thumb to any other finger on the same hand. This is called thumb opposition. Test for median nerve sensation by touching the pad of his index finger. Check the ulnar nerve function by asking the patient to spread his fingers apart. This is referred to as finger abduction. Check ulnar nerve sensation by lightly touching the pad of his little finger. The major peripheral nerves in the lower extremities are the femoral and sciatic nerves. Sciatic nerve testing is performed on the peroneal and tibial branches of the sciatic nerve. Check the femoral nerve motor function by asking the patient to straighten his knee. By touching the anterior thigh area, you can test for femoral nerve sensation. The peroneal branch of the sciatic nerve is tested for motor function by asking the patient to dorsiflex his ankle. The location of this nerve makes it especially vulnerable to pressure from traction devices. Peroneal nerve sensation is observed by touching the first web space between the first and second toes. Test the tibial branch of the sciatic nerve by asking the patient to extend his ankle. This is called plantar flexion. Tibial nerve sensation is tested on the sole of the foot. Be careful to warn the patient before touching the bottom of his foot. If he is ticklish, this test could cause him to jerk his foot, causing pain. These tests should be performed regularly, and the results recorded in the patient's record. Deviations from the patient's baseline need to be reported to the physician at once. A vascular or circulatory assessment of the patient's skin includes assessing skin color, temperature, capillary refill, and pulses. Healthy skin color in light-skinned patients is normally pink, which means the skin is receiving adequate arterial blood supply and has adequate venous return. If the skin is reddened, infection may be present. Pale white skin indicates inadequate arterial supply of blood, while a bluish cast can indicate inadequate venous return. When assessing deeply tanned or dark-skinned patients, skin color may not provide an adequate assessment of vascular function. Therefore, particular attention should be paid to capillary refill and skin temperature. Assess the temperature of the patient's skin with your fingertips. Remember to use the opposite extremity for comparison, and also take into consideration the room's temperature or the presence of ice bags or heating pads. The skin should feel warm to the touch. If it is cold, suspect inadequate arterial supply. If it feels hot, there could be inadequate venous return or infection. Capillary filling checks the strength of small vessel arterial supply. Gently squeeze the pad or nail bed of a finger or toe for 2 or 3 seconds, causing a blanching effect. Upon releasing the pressure, the affected skin should return to its normal color in less than 3 seconds. If the color takes longer to return, blood flow is sluggish and can indicate circulatory compromise. Pulses should be taken regularly as part of your vascular assessment. In the arm, pulses are assessed at the brachial, ulnar, or radial pulse points. The pulses in the lower extremities are the femoral, popliteal, posterior tibialis, and dorsalis pedis. Note the quality of the pulse. It should feel full. A diminished or absent pulse could indicate vascular compromise. The use of a Doppler ultrasound unit can assist in this assessment. Apply a small amount of electrode gel to the pulse site. Turn the audio switch on, apply the Doppler to the area, and listen for the pulse. If the pulse is very hard to find or very faint, mark the area so others will be able to more easily locate the pulse. Another nursing responsibility in caring for orthopedic patients is the assessment and care of the skin. Skin and soft tissue damage can occur from the original injury or surgery, or when a patient remains in a static position for too long. Continuous pressure impairs capillary blood flow to the skin. Pressure sores and tissue necrosis can be the result. Skin assessment should begin with a general inspection of the skin. Note the skin's color and integrity. Does it appear dry? Are there any rashes or open areas? Pay particular attention to all bony prominences and pressure points, such as the heels, sacrum, elbows, scapulae, and occipital area. Check the skin that is covered by or attached to the traction apparatus. These areas should be monitored very carefully for signs of irritation or pressure. Inspect any scarred areas or open lacerations for redness, irritation, or infection. If skeletal traction is in use, the pen site and the wound surrounding the pen should be inspected. The pen should be immobile, and the wound should be clean and dry. Assess for any signs of infection around the pen site, and make note of any redness, increased skin temperature, drainage, pain, or ridging where the skin appears tight and is pulling against the pen. Pen site care should be performed according to agency policy or the physician's orders. Skin care during traction involves cleaning, massaging, and patting pressure points. Anti-embolism stockings and external pneumatic compression devices should be removed at regular intervals for skin inspection and care. Skin should be washed often and dried thoroughly. Potential pressure areas should be massaged regularly. However, if an area has become reddened, avoid massage. Never massage the calf of the leg because of the risk of dislodging a thrombus. Padding such as moleskin, sheepskin, or foam may be necessary to protect skin from the traction equipment. The long periods of inactivity that traction requires can contribute to constipation. An increase of roughage, fiber, and fluids in the patient's diet can help combat elimination problems. Stool softeners, bulk agents, or laxatives may be necessary at times. Establish a schedule, provide for privacy, and use a fracture bedpan to facilitate regularity. Nursing assessments should document patterns of urine and bowel elimination, bowel sounds, any complaints of nausea or vomiting, and any abdominal or bladder distension. Breath sounds and respiratory rate and quality should be assessed and recorded regularly in order to detect early signs of impaired respiratory function. Encourage the patient to breathe deeply and cough frequently. Regular use of an incentive spirometer device facilitates deep breathing. Never ignore a patient's complaints concerning discomfort and pain. Such complaints need to be thoroughly assessed, documented, and reported, as they can be an indicator of developing complications, such as compartment syndrome. Patients in traction may experience depression, claustrophobia, and feelings of boredom and loneliness. Nurses should be sensitive to the patient's needs for emotional and psychosocial support. Assist each patient in maintaining control and autonomy by consulting them on daily schedules and planning diversional activities. Patients in traction present special challenges when providing personal care. Be careful not to bump the traction during this time. If the patient is in skeletal traction, instruct him in the use of the trapeze that hangs over the bed. Remind him that his limb is in balanced suspension, allowing him some movement without disturbing the fracture. Have the patient grasp the trapeze with both hands if possible. Ask him to flex his uninjured knee and hip and place his unaffected foot flat on the bed, parallel with the affected knee. Have him push down on the unaffected foot while lifting his buttocks off the bed. He should not bend at the waist. Change the bed linens from the top to the bottom of the bed. Remove the pillow and loosen the bottom sheet. Fan fold the clean sheet horizontally and place it under the patient's shoulders. Have the patient raise his shoulders off the bed by using the trapeze. Slide the clean sheet down to the patient's waist while pulling the old sheet at the same time. With an assistant supporting the traction, have the patient lift his buttocks off the bed and continue sliding the sheets to the foot of the bed. Pull the sheet taut to remove all wrinkles and tuck it in. When moving the patient up in bed, do not tug or jerk the patient against the traction. Make sure the weights and ropes are free of any entanglements. Have the patient reach behind and use the traction frame to pull themselves up in bed. Assist by easing the splint, but not the weights. Easing the weights releases the traction. Decreased muscle tone and atrophy can develop during long periods of traction. Nursing plans should include a schedule of exercise within the limits of traction. In addition to normal range of motion, all patients on bed rest should perform muscle strengthening exercises. Gluteal setting exercises involve contracting the gluteal muscles for a slow count of 3, then relaxing the muscles. Repeat 5 to 10 times every waking hour. Quadriceps setting exercises involve tightening the quadriceps muscle for a slow count of 3 by pushing the back of the knee into the bed or sling. Release and repeat 5 to 10 times each waking hour. Plantar flexion involves pointing the toes first toward the wall in front of you. Then dorsiflex the foot by pointing the toes toward the ceiling. Rotate the feet at the ankles first in one direction, then in the other. This promotes venous return and should be repeated several times every hour while awake. An understanding of the purposes and mechanics of traction provides a basis for the specialty practice of orthopedic nursing. Nurses skilled in treatment, assessment, prevention, and early identification of complications can play a vital role in the orthopedic patient's recovery from injury or disease.